We are the reporter and we are reporting about the fetus during labor. So learning objective. At the end of this chapter, the student should be able to identify the different sutures and fontanelles of the fetal head given a model. Define fetal lie, attitude, position, station, and presentation. Describe different types of fetal position and presentation. Differentiate among the complete, incomplete, and footling bridge presentation. Identify the best location for auscultation of fetal heart tones in the different types of fetal presentation. Identify the factors that affect audibility in the auscultation of the fetal heart tones. Discuss the measures of fetal status and well-being during labor. Fetal head. Fetal head is very important to study in pregnancy and childbirth because it is the largest and hardest part of the baby's body that needs to pass through the mother's birth canal. So the baby's head is made up of 7 bones, 2 frontal bones in the forehead area, 2 parietal bones in the side of the head, 2 temporal bones lower side near the ears area, and 1 occipital bones at the back of the head. So these bones are not yet tightly fused together. Instead, they are connected by sutures and fontanelles, which make the head flexible. This flexibility is very useful during labor because the bone can slightly move and overlap, making the head smaller and easier to pass through the pelvis. So there are the types of sutures. But first, sutures are thin space or joint between the bones of the body skull. Think of them as line where 2 bones meet. They are important because they allow the skull bones to move during delivery. They also help doctors and midwives feel the position of the baby's head during internal examination. There are 4 main sutures: the sagittal, that runs along the middle of the head between the 2 parietal bones. This is most important suture in labor. It allows the head to slightly overlap and reduces the width of the head, making it easier for the baby to pass through. And frontal sutures found between the 2 frontal bones in the forehead area. And coronal sutures runs from side to side between the frontal bones and the parietal bones. And lambent sutures found at the back of the head between the parietal bones and the occipital bone. And there are also the fontanelles. Fontanelles are the soft spots on the baby's head. They are the point where the sutures meet. These spots are soft because the bones are not yet fully closed and they are covered only by a membrane. So why are fontanelles is important? They allow the baby's skull to compress a little during labor. They give space for the baby's brain to grow after birth, and doctors can check baby's hydration or help by feeling the fontanelles. For example, a sunken fontanelle may mean dehydration. There are 2 types of fontanelles: anterior fontanelles or bregma, found at the top of the head between the 2 frontal bones and 2 parietal bones. It is a diamond shape, size about 2.5 cm by 2.5 cm. This is the biggest fontanelle. It usually closes between 12 to 18 months of age. Posterior fontanelles, also called as lambda, found at the back of the head where the 2 parietal bones and 1 occipital bones meet. It is triangular shape and much smaller than the anterior fontanelle. This closes every around 6 to 8 weeks up to 2 to 3 months after birth. Fetal head diameter. When we talk about the diameter of the fetal head, we meant the measurement of the baby's head from one point to another. These measurements are very important during childbirth because they help determine if the baby's head can fit through the mother's pelvis during labor. So there are 2 main types of diameters: we need to know the anterior, posterior, or AP diameters measure from front to back of the baby's head, and transverse diameter, it measures from side to side of the baby's head. Anterior, posterior or AP diameters, this is the distance measured from back of the head, occiput, to the front of the head, chin, or forehead. Occipitomental is 12.5 to 13.5 cm, measured from back of the head, occiput, to the chin. This is the widest AP diameter. When the baby's head is in this position, it makes delivery more difficult because the head is at its maximum length. Occipitofrontal has 12 cm, measured from the occiput, back of the head, to the mid-forehead, slightly shorter than occipitomental. Suboccipitobregmatic is 9.5 cm, measured from just below the occiput, back of the head, to the anterior fontanelle subspot on top. This is the narrowest AP diameter. When the baby's head flexes well, chin, trunk to chest, this diameter presents, making labor easier because the head is smallest in this position. And also has the transverse diameter. This measures the body's head from one side to the other, ear to ear area. Parietal diameter is 9.5 cm, the most important transverse diameter, measured between the two parietal bones to the widest part of the baby's head from side to side. This is the widest transverse diameter and is usually the one that needs to pass through the mother's pelvis. First, bitemporal diameter is 8 cm, measured between the two temples of the baby's head, smaller than biparietal. Bimastoid diameter is 7 cm, measured between the two mastoid bones behind the baby's ears. This is the narrowest transverse diameter. Fetal line. So the term fetal line means position of the baby's long axis, the line running from the baby's head to its buttocks, in relation to the mother's long axis in the line of her uterus and spine. In other words, it describes how the baby is lying inside the womb. There are three main types of fetal lie: longitudinal lie, transverse lie, and oblique. So, in longitudinal lie, this is the most common and normal type of lie. Our baby's long axis is parallel to the mother's long axis. Both are in the same direction. In this position, either the head cephalic presentation or buttocks or feet or bridge presentation enters mother's pelvis first. Since the baby is aligned in the same direction as the mother's body, delivery is usually possible through the birth canal. Example, think of the baby lying straight up and down inside the uterus, transverse lie. In this case, the baby's long axis is perpendicular or across to the mother's long axis. Instead of the head or buttocks presenting, usually the shoulder, back, or arm that is felt first. This is not normal for delivery because the baby is lying sideways. If the baby remains in this position, at the time of labor, vaginal delivery is usually not possible and may require a cesarean section for safe delivery. Imagine the baby lying side to side or horizontally across the womb. And the last one is the oblique lie. In this type, the baby is lying in an angle in the uterus. The baby's long axis is slanted compared to the mother's spine, not fully vertical like longitudinal or not fully horizontal like transverse. This is often an unstable lie, meaning the baby may change position and either shift into longitudinal or transverse before or during labor. If the baby corrects itself into longitudinal lie, delivery may proceed normally, but if it stays oblique, it can lead to complication. Think of the baby lying diagonally in the womb. Fetal attitude. The fetal attitude means the position of baby's body's part in relation to each other inside the womb. It describes how the head, arms, and legs are placed in relation to the baby's trunk, the body. Think of it as the baby's posture while still inside the mother's uterus. There are two main types of fetal attitude, the flexion and extension. So flexion is the desired attitude. In flexion, the baby's head is bent forward so that the chin is touching the chest. The arms and legs are also drawn in towards the bodies, and the back is rounded. This makes the baby's body compact and curled up, which is the most natural and common position in the womb. Flexion is the best and desired attitude during labor and delivery. Why is flexion is important? When the baby is flexion, the head becomes smaller and narrower because the smallest diameter of the head is present first, sub-occipital bregmatic 9.5 cm. This makes it easier for the head to pass through the mother's pelvis during the normal vaginal delivery. Flexion helps protect the baby by making the body fit better in the uterus and through the birth canals. So like a person curling into a tight ball, making themselves smaller to fit through a narrow space. So in extension, the opposite happens. The baby's head is tilted backward, inside, or off forward. The face or brow may present first, depending on how far the head is extended. The arm and body may also not be tightly drawn in. So the posture is more stretched out. So when the head is extended, the baby's head diameter that enters the pelvis becomes wider and larger. This makes it harder for the baby to pass through the birth canal. It can cause complication in labor, longer delivery, or even the need assist delivery like forceps, vacuum, or cesarean section.
So next is fetal presentation. So kapag sinabing fetal presentation, ito ay kung ano ang parte ng baby ang unang lumalabas sa panganganak ng nanay. So kapag pinaka-normal at safe na delivery is cephalic presentation kasi ang ulo ang nasa baba at madali ang panganganak ng nanay. So kapag bridge presentation naman is puwet or paa ang nasa baba, kaya mas risky ito dahil pwedeng mahirapan lumabas ang ulo, kaya kadalasan kailangan ang CS or cesarean section. So samantala kung ang transverse lie is nakahigap, pahalang si baby at sa tiyan ng nanay, kaya imposible na normal delivery ang nanay. So kailangan talagang i-CS or i-cesarean section ang nanay. So sa number 2 is fetal presentation, is ito ay tumutukoy sa kung paano nakapwesto si baby sa loob ng tiyan ng nanay. So lalo na kung ang parte ng katawan niya is nakaharap sa pelvis, nakaharap sa pelvic quadrants ng nanay. So sa harap or sa likod, at yung landmark ni baby is ang nagsasabi kung anong parte ang reference point. So kapag O is occiput or ulo. So kapag naka-cephalic or vertex ba si baby. So sa M naman is mentum. So kapag muka or kapag face presentation. So kapag sa S naman is sacrum. So puwet or bridge. So kapag shoulder presentation, ang pelvis ng nanay ay hati sa 4 quadrants. So left anterior at right anterior and left posterior and right posterior. So kapag sinabing LOA, left occiput anterior, ibig sabihin is ulo ni baby ang denominator at nakapwesto siya sa left anterior quadrant. Ito ang pinaka-common at pinaka-favorable kasi mas madali para sa mga nanay na manganak. So, kapag OP or occiput posterior is ulo pa rin ang denominator pero nakaharap si baby sa posterior or sa likod. So, ito ay mas mahirap kasi pwedeng magdulot ng matagal na labor or back pain si nanay. So, para malaman ang posisyon ni baby, ginagamit ang Leopold's maneuver kapag hinahawakan at ginapalpit ang tiyan ng nanay. So, ang FHT or fetal heart tones is ginagamit para makinig yung heart tones ni baby. So, sa vaginal exam is para ma-check ang sutures, fontanelles, at cervix changes. So, sa fetal station is sukat kung gaano kababa ang presenting part or karaniwan ay ulo. Karaniwan ay ulo ng baby sa pelvis. So, gamit ang axial spines is bilang landmark, floating high at ibig sabihin is hindi pa engaged. Mataas pa ang ulo ni baby. So, kapag station O is ulo ang nasa level ng axial. Spine is not engaged. So minus station is minus 1, minus 2. So, sa minus station is minus 1, minus 2. So, ulo ang nasa itaas ng spine. So, kapag plus station is plus 2, plus 1 and plus 2. So, ulo ang nakababa na papalapit sa paglabas. So, sa fetal heart tones or FHT is normal HR is 120 to 160 BPM. So, baseline is sa pagitan ng construction. So, variability, galaw o pagbabago ng fetal heart tone or sign na intact na ang CNS. So, ang long term is mabagal sa functionations. So, ang normal signs is absence, variability, or flat heart rate. So, pwedeng hypoxia, anemia, at gamot ang fetal anomaly death. So, marked variability is sobrang gulo ng HR or stressy baby. So, sa fetal heart rate changes is oscillation is HR above baseline. So, means is good sign. So, ang deceleration is below baseline. Below baseline is good sign. So, kapag decelerations is HR is below baseline. So, early is sabay sa construction or head compressions harmless. So, sa variable is biglang pagbagsak or cord compressions for relapse or not. So, sa nursing care is sa left side ng position ay oxygen or stop, oxytocin or check cord. So, sa late is bumababa ang heart rate or pagkatapos ng construction peak. So, na-fetal distress ito. So, sa stop oxytocin left is lateral oxygen or 8 to 10 minutes. So, sa IV fluids is prepared for delivery. So, sa other signs of fetal well-being is fetal movement. So, normal kung 3 to 3 beses ang galaw ni baby per hour. So, kapag meconium is passages or non-breech baby. So, sa danger sign is fetal distress over meconic para madaling tandaan. Or sa station is level ng ulo, mataas or zero spines. So, kapag plus is masyadong pababa. So, sa heart rate, life sign ni baby is 120 to 160 BPM beats per minute. So, dapat may variability, may oscillation. So, good oscillations is movement. And ang bad naman is absence, variability, late decels, all meconium, or non-breech.
Detection of FHR. Auscultation using a stethoscope. Every 30 minutes in early labor, every 5 minutes in transition. Count for 1 full minute. Ang auscultation ay ang pakikinig sa mga tunog ng katawan gamit ang stethoscope. Isa ito sa mga paraan upang masuri ang kalagayan ng sanggol habang nasa sinapupunan ng ina. Observe FHR. Tracing on an electronic monitor. The use of fetal electronic monitor is determined by hospital policy or the doctor. Ang FHR ay isang medikal na utos o mula sa isang doktor o nurse na nangangahulugang kailangang obserbahan o bantayan ang FHR ng pasyente o fetal heart rate. Fetal heart rate ay nangangahulugang fetal heart rate o pintig ng puso ng sanggol sa sinapupunan. External or indirect monitoring. Intact membranes. External o indirect monitoring ay isang paraan ng pagmomonitor ng tibok ng puso ng sanggol sa loob ng sinapupunan gamit ang mga kagamitan na inilalagay sa labas ng tiyan ng ina. Hindi ito invasive, ibig sabihin hindi ito pinapasok sa katawan. Ang external or indirect monitoring ay ang paggamit ng aparato sa labas ng tiyan ng buntis upang bantayan ang pintig ng puso ng isang sanggol sa sinapupunan. Dynamometer. Disc over fundus secured with belt. Ang dynamometer ay isang aparato na ginagamit upang masukat ang lakas, tagal at agwat ng mga pag-iri o uterine contraction ng isang buntis. Paano ba ito siya gamitin? Ito ay inilalagay sa tiyan ng buntis, karaniwan sa ibabaw ng matris. Hindi ito direktang nasusukat ng ang lakas ng contraction. Ultrasonic transducer. At the site of loudest FHR or fetal heart rate secured with a belt with conducting gel over the transducer. Ang ultrasonic transducer ay isang bahagi ng fetal monitor na gumagamit ng ultrasound upang marinig at masukat ang tibok ng puso ng sanggol habang nasa sinapupunan nito. Paano ba ito gumagana? Inilalagay ito sa tiyan ng buntis, kadalasan gamit ang gel para mas maging malinaw ang signal. Naglalabas ito ng ultrasound waves, hindi naririnig ng tao, na tumatama sa puso ng sanggol. Internal or indirect monitoring. Ang internal o indirect monitoring, fetal monitoring, ay isang paraan ng mas eksaktong pagsukat sa fetal heart rate at uterine contraction gamit ang mga instrumento na nilagay sa loob ng matris ng ina. Kaya ito mas invasive kumpara sa external monitoring. Kailan ba ito ginagamit? Ginagamit lamang ito kapag pumutok na ang panubigan or ruptured bag of water. Pressure transducer. An intrauterine catheter with water is inserted beyond the presenting part. Ang pressure transducer ay isang aparato na ginagamit sa panganganak para sukatin ang lakas ng uterine contraction, pag-urong ng matres, habang minomonitor ang FHR or fetal heart rate, pintig ng puso ng sanggol sa sinapupunan. Internal spiral electrode applied to the fetal scalp. Ang internal spiral electrode or ISE ay isang espesyal na maliit na electrode na ginagamit sa loob ng matres para direktang masukat ang tibok ng puso ng sanggol habang nanganganak.
So next is cephalic presentation, face. So cephalic means ulo ang nakauna, pero sa face presentation, ang mukha ng baby ang nakaharap sa birth canal dahil naka-extend ang ulo. So PMI or point of maximum intensity nasa ibaba ng pusod, umbilicus at sa gilid ng paa ng baby makikita ang malakas na tunog ng PHR or fetal heart rate. So bakit nga ba? Dahil yung likod ng baby mahirap mapalpate, kaya sa side ng paa maririnig ang heartbeat. So halimbawa, kung si baby naka-face presentation at nakatalikod ang likod niya, mas maririnig mo ang tibok ng puso na sa ibaba ng pusod banda sa gilid ng tiyan. So, kapag hinawakan ni nurse ang tiyan, hindi niya mahanap yung matigas o oksipot batok kasi nakaharap ang mukha ng baby. The next is bridge presentation o paang nasa ibaba. So, karaniwan nasa itaas ng pusod at sa gilid ng sacrum, buto o puwit kasi nandun nakaharap ang back ng baby. So, positions nito is left sacro-anterior o left sacro-posterior. Nasa upper quadrant ng tiyan. And right sacro-anterior o right sacro-posterior nasa right upper quadrant naman ng tiyan. So, example, kung bridge at nasa left sacro-anterior, maririnig ang heartbeat sa kaliwang itaas na bahagi ng tiyan. So, kung bridge at right sacro-anterior naman, maririnig sa itaas na bahagi. Factors affecting audibility of fetal heart rate. So, the first is PHR heard best through the fetal back except in face presentation. So, halimbawa nito is normal cephalic, likod ni baby nasa kaliwa. So, maririnig sa kaliwang side, pero pag face presentation, hindi sa likod kasi nakaharap ang ulo. So, next is obesity o polyhydramnios. Mataba ang tiyan o sobrang dami ng amniotic fluid, kaya mahina ang tunog. Halimbawa, buntis na obese, mahirap i-auscultate. So, next is faulty equipment. Halimbawa, sirang stethoscope o Doppler. And noisy room. Maingay kaya hindi marinig ng maayos. So, lastly is maternal gastrointestinal sound. Tunog ng bituka ng nanay. Pwedeng mapagkamalan na tunog ng puso ng baby. Normal baseline fetal heart rate 120 to 160 beats per minute. Uterus not contracting. So, PTS sound distinctly like a clacking, ticking. Other sound that may be auscultated include maternal sophol and fetal sophol. So, maternal sophol or uterine root produce a blood moves through uterine vessels mula sa ina synchronous sa maternal pulse. So, there does not guarantee fetal life. So, check count maternal pulse habang nakikinig sa fetal heart tone kung sabay ang tibok, which means maternal sophol. So, example, si nurse, naririnig ni nurse sa tiyan is tunog na whose sound sabay sa puso ni nanay, ibig sabihin maternal sophol, hindi fetal heartbeat. Next is punic sophol. Sound niya is purring. Sound over pregnant uterus.
So, mula sa fetus or umbilical cord vessels, same as fetal heartbeat, guarantees fetal life. Sa example, kung naririnig ni nurse ang tunog nasabay sa fetal heart rate, halimbawa 140 BPM, ibig sabihin fetal cord or blood flow, buhay ang baby. Next is bradycardia. Fetal heart tone 100 BPM, severe or 120 BPM mild. So causes maternal hypotension, hypothermia, hypoglycemia, drugs halimbawa beta blockers, late fetal hypoxia, congenital cardiac anomalies, then prolonged cord compression, and polyhydramnios o oligohydramnios. So management is oxygen may be administered. So example, kung habang nag-auscultate si nurse at fetal heart rate niya is 95 BPM, ibig sabihin bradycardia. Pwedeng may cord compression o hypoxia. So the last is tachycardia. Fetal heart tone 180 BPM, severe or 160 BPM mild. So causes nito is maternal fever, dehydration or anxiety, amniotic or infection, anemia, drugs like anticholinergic meds, or early fetal hypoxia, fetal movement and neurologic immaturity, and dehydration. So management, oxygen may be administered. So example, kung fetal heart rate niya is 175 BPM, ibig sabihin tachycardia. Pwedeng may lagnat si nanay or infection.